Hello, everybody, and a warm welcome to the latest edition of the IPC Partners Journal Club. Today, I have a very special guest to introduce to you, Dr. Phil Norville, known and loved by us all, who's going to be talking to us today about challenges and future perspectives in environmental decontamination. So today's a slightly unusual day in that Phil and I are together in the same room for once, but we thought we'd join from separate connections because that would make it a bit easier. So just a little bit of background then on the Journal Club and what it's all about, what we're trying to achieve with it. We set up this Journal Club for a number of different reasons. I think we wanted to try and establish an environment where people could talk about a topical paper, could begin to learn and to discuss topical issues, maybe to upskill a little bit in the way that they were addressing, accessing scientific information and beginning to learn from it. So today, hopefully, will be an example of a slightly different approach. We don't have a single paper to look at today, but rather a synthesis of information from a number of different sources. We're keen to try and foster a network of enthusiasts and have a bit of fun as well. So as always, IPC Journal Clubs are recorded and will be made available online after the event. And I'm sure Phil will agree that the thing that we love most about Journal Club is actually hearing from you and getting some input from the audience. So please do put your questions into the Q&A and general comments into the chat. And once Phil's finished, we'll hopefully have a really productive discussion. So Phil, over to you.
Thanks, Jon, and great to be here. So today, as Jon said, we're going to do things a little bit differently. I'm going to talk about a collection of different papers and research. Personally, I'm really passionate about the environment and how we keep it safe, and environmental decontamination plays a big part in that. So I've split my presentation into kind of challenges and then where I think there might be new solutions. And I'm going to think quite left field with this. I'm going to think about things that we aren't necessarily aware of or talking about from an IPC perspective. First thing for me to say really is that, decontamination is really, really important. And we know that there is very good evidence now for transmission of infections from the healthcare environment. This systematic review done by Brett Mitchell's group in Australia just shows that if you go into a room that was previously occupied by a patient with an MDRO, your risk of picking up that infection is a lot higher. And the only two things that connect those patients is the room. So prior room occupancy is a risk to transmission of these infections for things like MRSA, VRE. Therefore, the way that we decontaminate that environment is really important. And the transmission of these infections is also a real burden on our health service and on our patients. This is some data published a little bit a while ago now, but just showing the impact of these infections in England alone. So over 800,000 people acquiring an infection in hospital, 30,000 deaths, and look at the impact on the organisation. 7.1 million occupied bed days as a result of that. And also we get infections in staff, which has occupational challenges as well. If you put this into a model about what it costs our NHS in England alone £2.7 billion a year. So if we can just make a small impact on reducing the transmission of these infections by keeping the environment safe, then we can save our NHS money, which is really important in today's climate, and ultimately keep the patients safe. And where do these costs come from? This is a study done by Jon, actually, looking at an outbreak of CPE over a long period in 5 different hospitals. But you can just start to see how the costs of these outbreaks start to add up, looking at actual expenditure and then opportunity cost. And you can see that from the graph on my right-hand side. But if we think about what happens to patients when they develop an infection, they stay in hospital for longer, we need more treatment, we've got to do things differently from an IPC perspective, perhaps invest in anti-infectives. So you can start to see about how these costs start to add up. The other thing, just trying to paint a picture of the challenges that we face and why we need to think more cleverly, I think, around environmental decontamination, is these things that are coming over the hill. So AMR is probably the thing that keeps me awake at night. We're thinking about these multi-drug resistant organisms that are developing resistance to some of our last line antibiotics, and we've got almost pan resistance now. But this paper in the Lancet just highlights how significant the problem is. looking at a real high number of individual patient records and over 1 million deaths directly attributed to AMR infection. And you put that into context, that's more than AIDS and malaria. And a lot of these pathogens, they're kind of ones that we're familiar with all the time: E. coli, Staph aureus, Pseudomonas, etc. So AMR, obviously a big challenge. And I think that environmental decontamination can really play a role in reducing the rise of antimicrobial resistance by keeping these pathogens from our patients and reducing transmission risk. And this is just showing you about, if we carry on our current trajectory, we could be looking at 10 million deaths in 1 year alone by 2050. And there's lots of actions obviously going on to try and prevent the spread of AMR infections, things like vaccines and alternatives and surveillance. But I do think that environmental decontamination should be on that list as well. I love this cartoon, but we need to think about how these organisms are evolving as well. And environmental decontamination, in my opinion, is one way that we kind of can try and control some of these evolving threats. So these organisms, they spread these resistance genes, they evolve and mutate over time. So again, if we can eradicate these organisms in the environment and reduce the risk of their sharing antimicrobial resistance genes, we can try and prevent some of this AMR spread. Another big, challenge, and again, I think the environment is a significant factor in the transmission of this organism, Candidiasis, or formerly known as Candida auris. This emerging fungal pathogen, probably quite established now, and you can see from my map talking about where you've got outbreaks or different cases. But it's a huge problem because of its resistance to many antifungals and its propensity to be spread really quickly from patient to patient. We think that its ability to colonize the skin really quickly is a role in its transmission, and also for its form biofilms in the environment suggests that it allows it to persist in the environment for prolonged periods of time. So again, we need to think about how we decontaminate the environment because of these emerging threats. And again, just highlighting how significant some of these outbreaks can be. This is a case in the Royal Brompton Hospital. Just look at how many cases there are and look at the time period that they're over. 16 months, and actually observing hospital transmission. And those two factors that I talked about, environmental survival of the organism and colonization of patient skin, being real factors. And you can just see some of the measures that they started to put in, and lo and behold, enhanced cleaning and disinfection using HPV. So part of that environmental decontamination package was important. And the old enemy, C. diff. I think in my day job, we've experienced increases in our C. diff cases, and I think this is a national trend as well. As you can see here from this graph, we thought we were doing well against C. diff, but unfortunately, post-COVID, we've seen a national increase. So again, we need to think cleverly about how we deal with this organism. The ability for it to form spores means that it can persist in the environment for prolonged periods of time. So we need to think carefully about how we decontaminate. And then my favorite topic, biofilms. Again, trying to put this into the window of environmental decontamination. How do we eradicate these things from our healthcare environments? We're seeing multiple studies now with these organisms being linked to reservoirs within drains and sinks and showers, etc. So we need to be thinking a little bit differently about how we eradicate biofilms from our healthcare environments. This just explains what a biofilm is, and it's just essentially a collection of organisms attached to a surface surrounded by an exopolysaccharide, which is a slime or a gloop, which means that the disinfectants that we use commonly struggle to penetrate that outer matrix, which means that you get a lot of resistance to some of the commonly used disinfectants. And often they're multi-species as well, so we don't just have one organism, we have multiple ones. And we think about biofilms in different spaces. So I'll talk briefly about wet and dry. We also have medical device biofilms on things that go through various hydration phases. So we call them semi-hydrated. But I think we need to think really carefully about biofilms that persist in hydrated environments, so wet environments, but also this phenomenon of dry surface biofilm that I think we've seen really explode in the last 5 years from an IPC perspective. This idea that organisms surviving in dry environments for prolonged periods of time on things like bed rails, mattresses, and does that present a reservoir for infection? And how do we then environmentally decontaminate those devices? So just talking really briefly about wet biofilms and thinking that about how we decontaminate. This is a study done in Cardiff looking at the complexity of a biofilm within a common room, so not even a clinical environment. And just look at the diversity in that pie chart. You can see lots of different organisms represented by the different colors. And again, lots of those gram negatives that we associate with outbreaks with intensive care and augmented care units. Obviously not too concerned about transmission in this environment, but my key take-home message here is how do we develop a decontamination product or disinfectant product that's going to be effective against all those different species of organism, and they're encased in a biofilm as well. So again, just trying to highlight why we need to think maybe a little bit differently when it comes to environmental decontamination. And I love this study from Mark Garvey at the UHB, and I've talked about it in multiple talks before. But this is about how those organisms can potentially get out of those biofilms and contaminate our healthcare environment. So looking at how far these droplets are spread when you use a sink, up to 2 meters was the answer. And in that radius of that splash zone, they found lots of equipment in this study. So we've now got a bit of a mechanism for how that transmission occurs from biofilms in wet environments out into the patient environment. So again, how do we keep these systems safe? Do we actually think a little bit differently when it comes to environmental decontamination and maybe try and prevent the transmission by removing water in some of our augmented or high-risk areas? So there are schools of thought that say we should decontaminate or disinfect our sinks regularly, but what about if we take them all out altogether? So again, trying to think a little bit outside the box. And there's some really good evidence as well that shows that rooms with sinks in them have got higher rates of healthcare associated infections. So this is a study done in intensive care units in Germany, a retrospective analysis of 552 intensive care units. And lo and behold, the intensive care units who had single rooms with sinks in them had higher infection rates than those that didn't. How do we think about removing that risk, and how do we decontaminate those environments? And my last kind of problem before I go into the solutions, which I touched upon previously, was dry surface biofilms. You can see this really pretty electron microscopy image just showing that matrix, and look at the thickness of the biofilm on those surfaces. And these are all instances where we probably can't detect these organisms through normal swabbing methods. So again, if we can't detect it, but we've got it in our patients, how do we find it? How do we eradicate it? And quite often, I think we're finding that, these organisms are difficult to isolate in the environment because of our challenges around swabbing and how we replicate that. So is there maybe a move to more a metagenomic analysis or a molecular analysis to try and detect these organisms in the environment? And then what do we do to try and eradicate them? And this kind of highlights that point that I made. This is a study done in Cardiff looking at how much of shared medical equipment was contaminated with dry surface biofilm. And if you just do your normal swabbing methods, they weren't able to detect any dry surface biofilm in the environment. But the minute that you start to look under the electron microscope and you actually go and find these organisms, 96% of all those samples that were previously negative through traditional swabbing techniques came back as positive. And you can see in 3 different hospitals in 3 geographical locations, a large diversity of different organisms, mainly gram-positives actually, so Staph aureus and Bacillus. But again, challenges about how we keep that environment safe. And also they're very difficult to remove. This is just showing how mechanical action against dry surface biofilm is almost ineffective at removing these organisms from the environment. You had to wipe a surface 10 times to try and get anywhere near a 1 log reduction in dry surface biofilm. Whereas if you look at the planktonic in the blue bars, you start to get really good log reductions from 1 wipe. So again, we need to think a little bit differently about how we decontaminate the environment, because dry surface biofilms are difficult to remove. And then my final thing is about, okay, so if we do have the chemistry and the ability and the solution to decontaminate the environment, do we actually have enough time for our healthcare professionals to decontaminate effectively? And again, this is a study coming out of Australia from Brett Mitchell's group, looking at the time taken to decontaminate different pieces of shared medical equipment, looking at the removal of UV markers that you can't see with the naked eye. And I think what really struck me from this study is that, equipment to be decontaminated effectively takes a long time. So a commode to be decontaminated effectively takes almost 3 minutes. So do we give our healthcare professionals enough time to be able to decontaminate this shared medical equipment, given we're in a busy environment and we've got lots of other challenges around our patient needs and our patients' care? So I hope I haven't painted too drab a picture, but hopefully this is trying to set up how I think we need to think differently about our environmental decontamination. So just to remind you about the challenges, and we're going to go into the solutions now. So I've picked a couple, and this isn't an exhaustive list by any means. These are just some of the things that I think are maybe making a bit of waves and things that are really interesting from my personal perspective about keeping the environment safe. But there's plenty more out there as well. So just before I get into them, I think the first challenge that we have when it comes to environmental decontamination is that it means different things to different people. The way that we decontaminate in my organization or the way that we clean an environment might be different to my neighbor in organization 10 miles up the road. Their red clean might be different to my red clean. We might use different terminology. But this is the definition that the National Infection Control Manual gives you. And it's quite a lengthy one. But you can see maybe it's already quite confusing because we're talking about a combination of processes. So it isn't just one thing. It might include cleaning, it might include disinfection and or sterilization. But ultimately, it's about keeping the environment safe by trying to remove or reduce that risk. So I think the first thing we need to think about when it comes to environmental decontamination is how we standardize our terminology and how we can talk more collaboratively about what decontamination means to us as individuals. And the first thing to say is that we know that it makes a difference. So this is the CLEAN study coming out of Australia. Again, Brett Mitchell's group, who, if you haven't heard of him, I suggest you go look him up on LinkedIn or PubMed and look at his published research, because Brett has got a tremendous research group looking at taking about real evidence-based interventions to infection prevention control and making a difference. So in this study, they had an additional 3 hours of cleaning of shared medical equipment as part of a randomized controlled trial. And the graph on my right-hand side of my slide is just showing you the before and after, and the dotted line represents the intervention. So the first chart here is talking about the thoroughness of cleaning by the removal of invisible UV markers by putting in this extra 3 hours of cleaning a week. And they provided continuous audit and feedback as part of that process, which I think, again, is really important. We can't think about these interventions as being a one-stop shop. We need to think about how we continuously educate and feedback to our staff. And what you can see is that pre-intervention, their cleanliness scores were quite low. But as you'd expect, after increasing the amount of time spent to decontaminate shared medical equipment, they had a gradual uptick in the thoroughness of their cleaning. And then they looked to see if this actually made a difference in the infection rates in the organization, and they saw a 35% reduction. So I think it's really good evidence to show that if we improve the thoroughness of our environmental decontamination of shared medical equipment in this instance, we can reduce the bioburden in the environment, and then we can actually have an impact on our infection risks. And we know that if we improve our cleanliness and reduce our infection risks, that we can reverse some of these traits. We can improve patient safety, reduce treatment cost, reduce length of stay, and reduce pressure on the healthcare organisation, which is ultimately what we're wanting to do. So I think that the first thing to say is that we know environmental decontamination works, and we don't need to think about it as a siloed process. We need to think about the bigger trends for the organisation. Patient safety is paramount, but what does that impact in our organisation in terms of cost saving, flow, etc.? The second kind of thing that I want to pull out is this idea of multimodal strategies. So we think about interventions with environmental decontamination and perhaps changing a product or putting an additional product in. This slide really talks about how you can't do them in silos, that we need to think about combining things as part of a multimodal strategy. So don't just think about the product, think about how you apply the product, think about the education and training that goes with it, and how we keep that continuous improvement going through audit and feedback and communication. And again, this is a study looking at trying to put that in place in an organization, and just giving you an idea about the types of things that they looked at. So I won't go through them all in detail, but when you think about the product, you think about the efficacy, so what it kills, for example, if you're thinking about a disinfectant, but also the health and safety considerations and how you store it and how you get access to it. But then education and training, so providing a tailored program to look at techniques and manufacturer's instructions, and then communication, making sure that we're engaging with our staff so they know about what we're trying to do and how we continue to continually improve it and do our quality improvement to ensure that we keep going in the right direction, that we don't just stop, we don't just put an intervention in, that we continue going with good communication and audit and feedback. So this was a study called REACH, looking at implementing one of these multimodal strategies. It's a stepwise randomized controlled trial and across 11 separate Australian hospitals. And this bundle or this multimodal strategy involved all those things that I talked about on the previous slide. And they were doing it as part of their general hospital cleaning. And they looked at two outcomes. Aim was their infection rates for some of those organisms there, so C. diff, bacteremias and VRE. And then they also looked at the thoroughness via the removal of hospital cleaning via UV markers. And again, the multimodal strategy worked. Lo and behold, the dotted line is when the intervention started, and you can see they had a gradual increase in the thoroughness of the cleaning of these touch points in their bathrooms and patient bedrooms. And as you'd expect, continuous improvement, continuous feedback means that their thoroughness of cleaning increased over time. So you can see there, the weeks since the start of the control period after the dotted line, you've got a gradual increase in the cleanliness and the thoroughness of cleaning in that organisation. And again, it translated into a reduction in infections, not for all of them, but they did see a significant reduction in VRE, not MRSA and Clostridium difficile or Clostirides difficile infection, but they did see a reduction in their VRE infections. So again, it did translate over in some instances that improving the thoroughness of cleaning had an impact on their healthcare associated infections. The next thing, and this really is left field for me, I think when the concept of probiotics came on, for me, and I first read about them, this idea of artificially contaminating the environment with another organism just really went against all the principles of what we're trying to do from an environmental decontamination perspective. Ultimately, we're trying to remove organisms from the environment. But this idea of seeding the environment with organisms like bacillus is a really new concept. And actually, I've been really surprised that there's some really encouraging data about it coming out of Italy. So the idea is that you're using detergents containing spores of bacillus to contaminate your environment. And the idea is that these bacillus spores outcompete the multi-drug resistant organisms because they can't establish a foothold. I don't think we've quite established the mechanism for this, but the idea is that essentially they outcompete the multi-drug resistant organisms. So it's a big study done in Italy, this probiotic cleaning hygiene study. 5 Italian hospitals over 18 months, and they compared their probiotic cleaning with their conventional cleaning, which was using sodium hypochlorite or bleach. And they were applying these probiotics in really high concentrations, so 10 to the 7 per mil, applied every day in these organizations. And quite frankly, the results are staggering. They saw a tremendous amount of benefits. Now, they didn't carry out the study for 5 years, but they projected if they continued on their current improvement, what this would mean in terms of the number of infections averted and the cost saving that that would make across the organization. And they found that if they continued to model on the current trajectory that they would be saving nearly over 14,000 healthcare associated infections be averted every year, which translated into a 14 million euro saving. A lot of that saving is down to the treatment of healthcare associated infections, as we'd expect, increased treatment costs, increased patient stay, etc. And this is, the big challenge I think anybody is going to push back on is, do seeding the environment with bacillus result in people developing infections from that organism? And actually, in all their clinical samples that they dealt with across the organization, they didn't pick up a single bacillus infection. However, they acknowledge that we need to do more work in our vulnerable populations, because obviously our vulnerable populations might be more susceptible to some of these infections. So, this is a really interesting model about the potential use of probiotics. And again, there's a lot of people now talking about how there's some good initial evidence, but we need more. We need more high quality evidence. What's the best composition of these probiotics as well? Do we mix it with different strains or different organisms? I think bacillus is the front runner. And then what about the regulatory aspects as well and the risks for immunocompromised patients? But there is a movement. This is a recent narrative review talking about some of the positives, but also the need for more work. So I've got two more to talk about. Electrochemically activated, or ECA solutions, also known as hypochlorous acid, certainly in the UK generating quite a bit of interest. This is the idea of using electrolysis to activate water through that electrolysis process, generating hypochlorous acid. So this is talking about keeping water and wet environments safe. So this was in an A&E department in Ireland, I believe, and they were talking about whether or not if they could feed ECA into these wash basins through continuous disinfection, could they kind of keep biofilm at bay? So they put these 10 new wash basins in, and they put them into two arms, some of them being treated with ECA and some of them being used without any disinfection whatsoever. And you can see there a lovely image on the left-hand side of my screen showing you that if you use ECA, you've got that really clean pipework and no visible buildup of biofilm. If you look at the other side of the coin, you've got a clear buildup of biofilm there. So, is this perhaps a bit of a change in the way that we think about keeping our wet environment safe? Is it safe to continuously dose our water supply with hypochlorous acid? Work to be done there, but showing that it actually can make a difference in reducing biofilm in this particular example. And if we can't disinfect, what about if we can decontaminate? If we don't decontaminate, sorry, what about if we can design out? When I first saw this image, I was horrified because it just looks like a big slide, I guess, that I used to go on as a kid. But the idea here is that you generate an increasing gradient which prevents splashes. So preventing that splash zone that I showed you in that study from UHB, trying to think about how that might make an impact on transmission of these organisms into the environment. And again, this showed some really interesting results, prevented splashing and reduced the target counts of bacteria. And this might be a much more cheaper and robust way to keep splashes and transmission of infections out of our healthcare environments. My final thing is talking about a very different technology to ones that I've talked about previously, which is far UV. So again, we rely now in the UK on UVC technology, but we often think about that when our patients and staff aren't in the room. But what about if we could continuously decontaminate our environment using UV lamps that were safe at a wavelength where patients and staff could be in the room at the same time? So far UV uses a slightly different wavelength of UV light, and it doesn't penetrate the outermost layer of the skin, which means that patients and staff can be in the room whilst these lamps are being operated continuously. So this is a study done out of Scotland, looking at, okay, if we put these lamps into a chamber, does it actually make a difference when we artificially contaminate the room in the air through aerosolized Staphylococcus aureus? So putting these lamps in the ceiling and spraying effectively the pathogen into the environment. And you can see that it worked really, really well. You can see there that when the lamps were turned on, you had a really big reduction in viable airborne Staph aureus. So again, I think far UVC shows some promise there. And they had some really good reductions in aerosolized Staph aureus when the lamps were turned on. People have gone one step further and they've actually put this into a real world setting. So I learned that actually in an animal care facility in mice, that murine norovirus is actually endemic. So it's a really good testing house. So they put these UV lamps into the environment, and they looked at sampling over a 4-month period. And again, they saw a 99.8% reduction in infectious airborne murine norovirus. So talking about putting this into a real world setting and actually making a difference. And my final slide, bang on where I wanted to be with timings, was talking about, okay, so if we can't decontaminate, what about if we think differently? We've talked a little bit about engineering, but what about if we remove the risk completely? So this is a study in Geneva talking about removing water from healthcare environments. So they did looking at substitutions, essentially using things like bottled water or more disposable single-use equipment to try and put water-free care in. And lo and behold, in this case, they eradicated their outbreak, which had been going on for a really prolonged period of time in 21 different patients. So again, I think water-free care or water light or water safe care is gathering a bit of traction in the IPC world. So is there a role for this as well? So just to finish, I think that hopefully we've shown you that the environment plays a real role and that a lot of those risks around things like AMR, multi-drug resistant organisms, and emerging pathogens are a real risk for us. We need to think about multimodal strategies. We need to think about innovation, and we need to think about all these different things that we've got in front of us to talk about keeping the environment safe. And there's things that I didn't even get onto, but what about things like self-disinfecting surfaces, use of bacteriophages, light-activated disinfectants, and then where does sustainability play a role in all of this as well? So take home message, environmental decontamination is important. Do we need to think outside the box? I think we do. We need to engage with industry. Innovation is key. And let's see where we go from there. Jon.
Okay, thanks, Phil. That was fantastic. You said you're only going to talk for 10 minutes, so I don't know why you got to half an hour. I'm kidding. It was really great. So please, questions coming into the Q&A. My goodness me, what a lot of things that we could talk about, and huge and important questions this raises. Can I just take you back to your helter-skelter to start with, the drain pipe with the shallow gradient that looked a bit like a slide? I thought that was an interesting idea, but wouldn't you think that having a really shallow gradient on a drain would make it worse and you get more build-up?
It's a good point. And I think it's all about reducing splash. So I think that in the second slide that I showed, they actually did show that the counts of organisms were slightly lower. So I'm not entirely sure about the kind of, what's the right word, the dynamics of those organisms in those environments. They're still there ultimately, so they didn't eradicate them. But I think it's thinking more cleverly. You know, if you look at the work that Mark presented around the splash zone, can we kind of engineer the risk out a little bit? So I think I agree with you. You know, it's not going to solve the problem, but if we can't remove the organisms by disinfecting them, can we think about, you know, engineering controls that reduce that spread and reduce that transmission that way?
Yeah, okay, interesting. So a good question from Ajoma here. Could you comment on standardization of testing for agents used in decontamination? Do we need to have planktonic methods, biofilm methods?
It's a great question. And to be honest, I was going to say it's a minefield. And maybe I'll stick with it is a minefield because there are so many different European standards or EN norms out there when it comes to disinfectant testing. And I think even I struggle to keep pace with the changes in the landscape and the fact that there are always new ones coming. So we've got lots of different EN standards and they work against organisms in different germ groups as well. So we can talk about ones that are just effective against bacteria, ones that are effective against yeast, and ones that are effective against spores. But then we've also got different techniques within that. So we might talk about directly immersing that organism within a disinfectant, like a suspension test, or then we might talk about putting in a wiping action as well. So talking about more real world setting. So within the planktonic, there are lots of tests to choose from, and I think it's really important that we work with our suppliers to ensure that those tests are right for the environment and what we want to try and eradicate. When it comes to biofilms, there is standards in development. I don't think they're quite ready yet, but I think that there is a trend to try and standardize the way that our products are tested from a disinfection perspective, because we are now more appreciating the role of biofilms in the transmission of these organisms and these infections. So we need standardized testing. So I guess for planktonic, there's plenty out there and there's lots of variation, and you need to think carefully about the ones that are claimed and making sure that they collaborate with the manufacturer to justify those claims. And then when it comes to biofilms, there is differentiation coming, but it will just take a little bit more time, but watch this space.
Okay, great. Thank you. Interesting. I agree. I mean, standards can be bamboozling and it's so difficult to keep a track on. I think we need to move away from suspension testing as kind of the basis of hard surface disinfectant testing, because it's so different to what the organism is going to be encountering in the real world, or how things are configured, and all the various cofactors. Okay, can I take you back to far UV, which is a really interesting idea. I suppose my main question with far UV is the level of reduction that you see with far UV, which is moderate from a microbiological point of view, do you think that's good enough to translate into a meaningful reduction in transmission risk?
That's a great question. I think the jury's still out on that. So we don't have, I think we've got the kind of proof of concept stuff at the moment and showing that we know that the technology can work and we think the technology is safe as well. But we're lacking that kind of, real hard-hitting evidence that it's actually going to make a difference in the transmission of these infections. Personally, though, I think that anything that's going to reduce the bioburden in our healthcare environments should make a difference. We know that the environment plays a huge role in the transmission of these infections. So if we can have something that's working continuously to keep the bioburden at a low rate, I think that will play a role in reducing the transmission of infections, because we know that, we do have heavily contaminated areas within our patient rooms and our patient environments. And we know that some of the traditional techniques that we rely on, they require time, they require input, they require a good operator. So we need to make sure that the person using the wipe or the mop or whatever it is they're using is using it in the correct manner. So if we engineer that out a little bit and rely on, machines, if we can, to kind of give us that continuous level of low level disinfection, I think that could make a difference in keeping the bioburden low to try and make an impact on transmission that way.
And I wonder whether there's a really nice potential synergy between surfaces that are coated or treated to make them antimicrobial and far UV light, or something around the synergy between those two technologies is quite appealing, I think. Okay, next question from Patricia, thank you, is you commented on several different approaches to disinfection that are not chemical based. What about enzymatic cleaners? Is that something we could?
I asked this question at another talk recently, and I definitely think there's something there as well. I mean, whenever I think about enzymatic, I'll think about breaking down that kind of first layer of defense from a biofilm perspective, certainly. And I think now we're seeing that within biofilms, we know that our disinfectants can't necessarily penetrate that real slimy layer that the biofilm is, or the organisms within the biofilm are encased in. So I really like the idea of trying to introduce something that will break down that kind of matrix. And if you think about how the majority of our healthcare organisations in the UK work, they combine processes. So they'll use like a detergent and a disinfectant in a combination. So I think there could be something here in trying to combine enzymatic cleaners with disinfectants. I mean, I don't have enough experience of enzymatic cleaners alone to know that they will make a difference. I mean, the concept is great, that it's actually going to get into and penetrate and break up maybe that matrix which is keeping all these organisms together. But I guess, could we do it in conjunction? So we could have put an enzymatic cleaner in to kind of break down that matrix and then allow the disinfectants to actually get in and do their work, because we know that within biofilms it's that first layer of defense, which means that a lot of antimicrobials, and that extends to antibiotics as well, that they can't work. So I think enzymatic cleaners could be really interesting, and I'm really interested to hear about that. Oh, it's combination with steam as well. Okay, I think that could be great. Yeah, I think that you've kind of got the two in combination there. So yeah, I think there's definitely there in enzymatics.
Okay, Phil, I think we could be onto something here. We've just invented a collaboration or a synergy between far UV and antimicrobial surface coatings and enzymatic cleaners and disinfectants. So I think we better patent it all quickly. I'm sure it's not the first time people have thought about these things. Okay, a sort of practical question about how all this is going to change practice. You referenced the CLEAN study, which is just fantastic. Randomized controlled trial, nice big impact on reducing healthcare associated infection, but requires an investment 3 hours per day per ward of enhanced cleaning focused on medical equipment. Is this something we should do? And do you think there would be organizational appetite to do it? And do you foresee any practical barriers to actually implementing that kind of model?
Yeah, I think it's the best evidence that we've got, in my opinion. given how robust the study is, and also, the outputs. And I think it's actually quite a small change. I often talk about, the importance of our domestic staff as well as our clinical staff when it comes to keeping the environment safe. But I think that it just shows that if we can improve the thoroughness of our cleaning, then we can reduce our infection rates. The study actually has gone one step further, and they've looked at what that means in terms of the economic analysis. And it's really good news, as you'd imagine. So I think that actually to convince our organizations about how we need that investment and how we need that implementation of things like this intervention in terms of increasing the frequency of the cleaning of our healthcare environment, we have to kind of join all the dots. So we've got to show return on investment ultimately. Patient safety is obviously crucial, and we want to reduce the transmission of these organisms. But I think what our C-suite, our decision makers within our organizations want to see is, this is great for patient safety, but what does this mean for our organization from an operational perspective, from a pounds and pence perspective? And the good news from the clean study is that it really does save money as well. As you'd expect, if you can reduce these infections, you keep your patients out of hospital for a prolonged period of time, you reduce your treatment costs. So I think the evidence is growing. I think there's still a little bit more work to do about how we embed this within our organizations and justify that initial upfront investment and that it pays back on a local level. But I think we're in a good place. And if you look at the evidence base that we've got now for the environment versus 20 years ago, where people didn't really necessarily think it made a difference, I think now we're kind of squaring the circle and showing you that if we do look after the environment, then we reduce infections and save money at the same time.
Okay, thanks, Phil. So taking you back to earlier on in your talk, where you mentioned the idea of undetected dry surface biofilm on a surface. But looking into your crystal ball in the kind of 5-year, 10-year time frame, do you think we're going to have hugely better visibility of either biofilms or on surfaces, or rapid detection of specific microbes on surfaces? And how's that going to change the way we approach disinfect?
That's a great question. I would love to have a device that I could just shine onto a surface and show me dry surface biofilm or biofilm, whatever it is. And I think that if we think about how we're going to implement maybe some simple processes to try and get on top of this problem, I feel if you can visualize something, you can show people that it's there, and then they can do something to try and make it better or remove it. So, I'm a big fan of, if we talk about detection, I'm a big fan of molecular techniques. I just worry about whether or not they can actually exist in a busy healthcare environment, and whether or not we've got the resource, the staff, the investment to be able to kind of do it routinely. I think, if we think about interventions within IPC, a lot of them are off the back of investigations or outbreaks. So I'd love it to be done more routinely, but in terms of sampling, but then twinned with an intervention. So showing that we're detecting it, and then showing that we can do something to actually target what's there, and then trying to prove that actually that makes a difference in the long run. So kind of going through the whole process, really, routinely identifying it, having something that we know is going to be effective about removing it, but then showing to the organization or to the key stakeholders that actually by doing that we can get good results, improving patient outcomes. So I don't have a crystal ball to say that I think it's going to be there in 5 years' time. I think we need to do work to prove that if we've got techniques that we can use to detect these organisms, but also got the products and the capability to remove them. And I think there's still work to do there, by the way, in terms of the products that we use and the application methods. And if we can show that it makes a difference, then it might become more routinely embedded in day-to-day practice.
Okay, thanks, Phil. I just want to get your comment on one thing that's come through the chat in the meeting, and then I've got one final question for you before we conclude. So prepare for that. So the comment is around the interaction between manufacturers of disinfectants and disinfection technology and end users, and whether there can sometimes be a bit of a disconnect between the two, perhaps talking slightly different languages, and what can be done to improve that dialogue.
Collaboration, I think. And I think that we have to ensure that the people who are producing our medical devices are working with the companies that provide the products that decontaminate the environment. In my organization, we kind of vet a lot of our equipment that comes into the organization to make sure that it's compatible with our current cleaning policies and the disinfectants that we use. And I think that there's a place to be had about that collaboration between people who manufacture equipment and then people who provide the recommendations, or sorry, the products that are used to decontaminate them. So I think it has to be joined up. I think industry needs to work together as well as bringing in our healthcare organizations. And I need to kind of think one step ahead. So this equipment that we're bringing in, is it compatible with what we currently do? If it doesn't, can we test it, and can we get some assurances, on both sides of the fence to make sure that we collaborate that way?
Okay, one final question before we conclude then. So you've talked about a wealth of options, many things we could do to try and improve surface disinfection in healthcare. If you could do one thing or improve one thing, what would you choose? Where would you start with this?
That's a great question. And I've got two answers. The one would be if I really wanted to kind of grab something which was left field and just experiment whether or not actually make a difference. And if it was that, I'd go with probiotics, because I think the concept's a bit mind-boggling, but the early research, is really positive. So I'd love to look at probiotics and see if that made a difference in just one of the areas in my organization where I might have had an increased incidence of infection. If I had one option, it would be increase the resource and the time spent around cleaning shared medical equipment. And I would put in one person who was solely responsible for cleaning shared medical equipment. I would make the cleaning of shared medical equipment a profession. I would make it somebody who knows exactly how to clean a neonatal incubator, a drip stand, a mattress, and they could do it routinely and thoroughly, and they could go and educate all my clinical staff on how to do it properly.
Okay, so we've agreed we're going to implement a shared medical equipment cleaning and disinfection czar who's going to be singly tasked with making sure that it's done properly. Love it. Okay, brilliant. Thanks everyone for joining us today. That was a really, really helpful session. Just to let you know, next Wednesday, we have an IPC Journal Club special in partnership with ARCA. We're going to be focusing on gloves, when to use them and how to choose between them. It's very topical because it's around World Hand Hygiene Day, which comes around next week. And the motto this year is always hand hygiene, baby gloves. Which is a great motto and very on topic with what we'll be talking about next week. And then looking further into the future in June, we're in the final stages of planning an IPC Journal Club in partnership with the Healthcare Infection Society, looking at an MRSA special edition in the Journal of Hospital Infection and Infection Prevention in Practice. So with that, we'll sign off for today. Thanks very much for joining us, and we hope to see you again soon.